For those of you just joining, we're just going to give a few minutes for everyone to hop on here, and then we'll get started. Thanks for coming this evening. I'll just wait another minute for a couple stragglers to hop on. All right. Well, I think I'll get started here. First of all, I'm Dave Stewart, Athletic Director with the Winter Sports Club, and I've been here for about a year, and I've really enjoyed being in the community. And we have a great partnership with UC Health and Mary Beth Strobeck from UC Health. We partnered together, and she did an awesome job pulling together a panel from within the organization to discuss some topics related to female participation in sport. This evening, we'll have Dr. Jessica Devon, Kara Mars, and Cheryl Tenpass presenting to us on the topic of the female athlete triad. I was a coach. I was just mentioning to these three that I was a coach at the NCAA level for a number of years, and had some experience with this topic. It's very important, very common, I think more common than people realize. So I'm really looking forward to the presentation this evening. For the agenda tonight, we're going to start off with Dr. Devon, then move to Kara, and then Cheryl. We're going to have presentation length of around 15 minutes with 5 minutes between for some question and answer. And at the end of all the presentations, we'll have some opportunity for 20 or 30 minutes of discussion. This is a webinar, so everyone's muted automatically. So when people have questions, please just raise your hand or type a question into the chat box, and I can unmute you so you can ask a question, and we can have a good discussion that way. At the end of the conversation, I'll try to maybe unmute a bunch of people at once so people can have a good conversation towards the end. I'll do a quick bio so everyone knows who's speaking tonight. I'll start off with Dr. Devon. Dr. Jessica Devon, MD, is an endocrinologist here in Steamboat. She's board certified in endocrinology and has practiced in both academic and private practice settings since 2007. She was previously a faculty member at MD Anderson Cancer Center in Houston, as well as at Vanderbilt University Medical Center in Nashville. Accomplished in research, Dr. Devon has co-authored numerous journal articles and has been invited to present her knowledge in a variety of professional settings. In her practice, Dr. Devon strives to establish collaborative relationships with all of her patients and the referring physicians to best diagnose and tailor their treatment plans. She is thrilled to be living in Steamboat Springs with her husband and their children, and to have this opportunity to provide endocrinology care to the people of Northwest Colorado. Welcome, Dr. Devon. Thank you.
Thank you.
Kara Mars is a registered dietitian and nutritionist. Kara has lived in Steamboat for 24 years and studied at Colorado State University and Central Michigan University, as well as a year-long medical internship at the Mayo Clinic School of Health Sciences. Currently, Kara is a multi-year program studying functional medicine and has a deep love of sports nutrition, having worked with many athletes from recreational athletes to Olympians. As an athlete herself, Kara was a coach for SSWSC for 10 years with her husband Dave, and is proud that her almost 9-year-old son Max is now an SSWSC athlete himself. Kara is an avid skier and ultra runner and has competed in many events of marathon to 100-mile length, noting that nutrition plays a key role in every one of them. Welcome, Kara. And last but not least, Cheryl Tenpass, physical therapist. Cheryl earned her doctorate in physical therapy from the University of Rhode Island in 2009 and has been practicing at Sports Med for 2 years since moving to Steamboat Springs. As a specialist in pelvic physical therapy, Cheryl treats conditions that involve pelvic pain, urinary and bowel dysfunction, and pregnancy-related pain, in addition to regularly seeing patients with orthopedic injuries. Cheryl's specialty certifications include Certificate in Achievement in Obstetric Physical Therapy, Certificate of Achievement in Pelvic Health Physical Therapy, 300-hour yoga therapist, and certified lymphedema therapist. Cheryl, welcome. Thank you. All right. And we'll start off with Dr. Devon here, and I'll control the slides, Dr. Devon, so I'll pull that up and share my screen, and we can get started. Okay.
Let's see. Dave, I think we have to go back a few. There we go.
There we go. Yep.
Perfect. Thank you. Awesome. All right. So as Dave mentioned, the topic for this evening is going to be the female athlete triad, or the relative energy deficiency in sport syndrome, as more recently dubbed by the International Olympic Committee. And you can move on to the next slide, Dave. And so as the first speaker for tonight, I'm just going to go over the three components of the female athlete triad, which are energy availability, menstrual function, and bone mineral density. I'm also going to share a little bit about the screening and the diagnosis of the triad. And then my colleague Cheryl is going to go over some of the physical therapy aspects of this in regards to health consequences and performance effects. And Kara, of course, is going to go over the prevention and treatment through nutrition. And so this figure was adapted from the American College of Sports Medicine, and it goes over the three aspects of the triad, which we really think of now as three interrelated spectrums, where you have the healthy female athlete over on the right, who has optimal energy availability, regular menstrual cycles, and thereby has optimal bone health going forward in life. And then moving along this spectrum down to the unhealthy athlete who has low energy availability and the absence of menstrual cycles, and over time is at great risk for the development of osteoporosis. And so it's really this concept of energy availability, which is the first aspect of the triad that I really want to highlight, because I think this is really the key to understanding the triad and the consequences of it. And so when I think about energy available, I think of it in terms of a mathematical equation where you have the dietary energy intake, or what the athlete is taking in nutrition, and then minus the exercise energy expenditure, or the calories that athlete is expending in their exercise. And so ideally you have a positive number for their energy availability. But if you have a decrease in energy expenditure or an increase in exercise, you are at risk for developing a negative energy availability or a deficit in energy. And that can lead to some of these consequences of the female athlete's triad. And so I think when a lot of people think of the female athlete triad, I feel like a lot of people automatically jump to having an eating disorder. And that's really not the case the vast majority of the time. And so really the vast majority of the time you simply have a mismatch. And so I've put a couple of different scenarios on to really highlight this. And so for example, scenario number one is when an athlete keeps their diet stable, but their energy or their exercise is increased. And that will wind up with a negative energy availability. Scenario number two, the exercise is stable, but the diet is decreased. And this can be intentional or completely unintentional. Maybe there's just not enough knowledge about the amount of nutrition that needs to be taken in, or the athlete's not taking the time to eat adequately, or they don't have an appetite that's sufficient enough to take in enough nutrition. And then the last scenario is really what we see the minority of the time, and that's where disordered eating is unfortunately present. This can be more of a restrictive eating pattern with anorexia or bulimia, or the abuse of laxatives or diuretics. And so the number two component of the triad is menstrual dysfunction or loss of the menstrual cycle. And again, getting back to this concept of energy availability. And so the energy that is available, which is left over after you take away energy expended from the amount of nutrition taken in, is what is left over for basic physiologic functions. So controlling your heartbeat, building muscle, and maintaining your menstrual cycle. So these are all basic functions that rely upon energy availability. And the reason that we focus on the menstrual cycle is it's a marker of adequate energy availability in a female athlete. And so when we're talking about menstrual dysfunction, we have two medical terms we use for that. First is primary amenorrhea, which is when an athlete doesn't have any cycle at all by age 15. And the second is secondary amenorrhea, when an athlete once did have their menstrual cycle, but then it goes away and they have not had one for at least 90 days. It's important to note that in young women, the cycles can be irregular at first, and anything occurring between every 21 and 45 days can be completely normal. The term functional hypothalamic amenorrhea is something that you'll also see, and that is the medical term that describes the characteristic pattern of hormone abnormalities we see in athletes who have lost their menstrual cycle. So reduced energy available actually causes a disruption in pituitary hormone secretion, specifically the LH and FSH levels coming from the pituitary gland, which control the estrogen and progesterone at the level of the ovaries. And so it is, again, this reduction in energy availability that then reduces the pituitary hormone secretion, reduces the estrogen and progesterone, and leads to loss of the menstrual cycle. And the third component of the female athlete triad is bone density. And bone density occurs as a direct result of the loss of estrogen and correlates directly with the loss of menstrual cycles missed. So bone density is referring to how dense your bones are. So over in the bottom right of the screen, you can see a densitometry machine, and that is what is used to measure bone density. And in premenopausal women or young women, we use Z-scores to quantify bone density, and that is a score comparing your bone density to your peers. If anything, a young athlete should actually have denser bones than their peers due to all of the exercise that is taking place. And so if you have less dense bones, and that is really of great concern and is a big red flag. And I have the two diagrams on the top right for you to better visualize what I'm talking about when I mention the term bone density. So on the left, you can see healthy bone, and then on the right, we have osteoporotic bone, which looks a lot more like Swiss cheese and is at greater risk for fractures. I think the term osteoporosis, I more correctly apply to the postmenopausal population, and below normal bone density is a term that we more use in the younger premenopausal population. But again, the development of a decrease in bone density is a direct result of the menstrual cycle's miss and the loss of estrogen. And although a young athlete's probably not thinking about bone density at this point in their life, when we think about determinants of osteoporosis much later in life, one of the big determinants is that a person never reached their optimal bone density to begin with during adolescence. So actually greater than 90% of bone mineral content is achieved by 18 years, with peak bone accrual between 11 and 14 years. So that adolescent timeframe is really a critical time period to have adequate estrogen and really be building your bones. And so moving on to some of the screening and diagnosis, I'd like to talk a little bit about risk factors and what athletes might be at risk for development of this syndrome. So athletes who limit the types of food that they eat, whether it's intentional or unintentional, perhaps someone has a medical diagnosis in which they have to follow certain dietary restrictions. Those individuals must be very careful to make sure that they're getting adequate nutrition. Dieting, a choice of vegetarian or vegan diets, those also must be done very carefully. Early start of sport-specific training, as well as sudden increase in training volume. So going up in an age level in your training and adding a number of hours of training per week must be accompanied by an increase in nutrition as well. any athletic discipline that favors leanness, and then really anything with a high calorie expenditure. And I adapted this chart that I found on the internet, including several of the sports that are common here in Steamboat, so that you'd have an idea and a comparison's sake for the number of calories which can be burned in an hour for a given body weight with all these various sports. And these are, this is one of the screening questionnaires, which has actually been put forth by the Female Athlete Triad Coalition Consensus Group that could be used, for example, at the time of a sports physical. And so these are really common questions that you can ask yourself and go through. And again, if you answer yes to some of these, have you ever had a stress fracture? Are you taking any female hormones or contraceptives? When was your last cycle? Then perhaps it's a consideration for further evaluation. And so a little bit about the laboratory evaluation and physical exam. So my role as an endocrinologist, usually I see adults or young adults if they have lost their menstrual cycle. And so my role is basically to make sure that there is nothing else that is going on, which is contributing to the loss of the menstrual cycle. And we do, of course, check the pituitary hormone levels and the estrogen levels, and we look for the classic findings there. Of low levels in each of those. But we also want to make sure that we're not missing anything. And so different disorders that we consider checking for may include polycystic ovarian syndrome, pituitary disease, thyroid disorders, high prolactin levels, adrenal gland disorders. Upon physical exam, there's nothing that is pathognomonic for the female athlete triad, but we do frequently see a low pulse rate. That's very common in athletes. We can see some findings of coarse hair, particularly on the arms and legs. Sometimes athletes do complain about some alternating problems with constipation or diarrhea, and they can have a little bit of edema as well. Cheryl's really going to dive much more into the health consequences and performance effects. But again, I just want to highlight the reduced energy availability that's characteristic of the syndrome leaves less energy available for basic physiologic functions. So you are at risk for increased risk of infections and illness, the decrease in bone density that I previously mentioned as well. And some of the performance effects are also an important consideration because at the end of the day, this is what everyone is striving for, of course. But if you have reduced energy availability, then you don't have enough energy left over for protein synthesis, and you have decreased muscle mass, dampened immune system, increased risk of getting sick. And because you are not optimizing your bone health and your bone density at an increased risk for stress fractures. And so Kara is really going to go ahead and dive into this in much more detail. So the goal of treatment is restoration of the menstrual cycles as a clinical marker of reestablishment of energy balance and future improvement in bone density. And so this really involves a skilled sports nutritionist to focus on what is causing the low energy availability and addressing this with the assistance of that nutritionist. And treatment with medication. So I really do discourage treatment with any medication. And the medication that we do consider using is usually oral contraceptives. So oral contraceptives have been, I should more correctly say oral contraceptives have been used much more in the past. But really what we consider using now is transdermal estrogen therapy with progesterone. So it used to be that oral contraceptives were frequently used in this population, but as time and studies have accumulated, the data on that has become much more controversial, and is believed that oral contraceptives might actually cause a bit more harm than good due to dampening of some of the other hormone axes. So if we are considering an estrogen or progesterone, then we will go more towards a transdermal estrogen patch to replace the low estrogen and progesterone levels. And the thought process behind this is we're replacing the estrogen that is low in an effort to protect the bones and maintain bone density. So given that, the time when I will consider an estrogen with progesterone is if there is prolonged absence of the menstrual cycle, or if an athlete is having a really tough time going forth with the nutrition interventions, or if there has been stress fractures. To address bone density, it's very easy to get dairy into the diet. If that is an issue, you can always get calcium in the form of calcium citrate. We typically recommend anywhere between 1,000 and 1,500 milligrams a day, with 2,000 international units daily of D3. And then in the minority of cases, when there might be an eating disorder present, then that is definitely under the direction of a mental health professional. Yeah, we can, I think there's perhaps one more slide. There we go. And so I just want to highlight that the recovery from the female athlete triad, the first focus is really on the maintenance of energy availability, which then over a period of months does result in recovery of the menstrual cycle, and then over years recovery of the bone density. So I'm going to turn it over to Kara to talk a little bit more about the nutrition.
Thank you, Dr. Devon. And maybe just before we move to Kara, I just want to see if there are any specific questions relative to your presentation as well. Anyone would like to raise their hand from the group here? Go ahead, John. I think we had one question here. John, did you have a question?
I think it says, never mind.
Never mind. Okay, I didn't see it. Great. Okay. Anyone else? If you raise a hand, there we go. All right, Tim, go ahead. Tim, had you raised your hand with a question? Maybe not. Tim, are you there?
Hello?
Hello.
Can you hear me okay?
Now I can hear you. Great.
Okay, here we go. Yeah, I just had a quick question around if, as a coach, how would we escalate or communicate concern if we thought, if we had concerns about an athlete?
Jessica, do you want to take that?
Well, actually, I was wondering if you wanted to take that.
Yeah, I'd be happy to. I mean, I think what I would say was, I think that it's an important thing to bring to the athlete's parents first, certainly. Yeah. And then from there, I think the question that I written down during Dr. Desmond's presentation is, if, as you say, prevention is key, right? And if that's the case, what's that first step if energy imbalance is a concern?
What is the first step if energy balance is a concern after it brought to the
for a parent?
For the parent?
Yeah.
I think two things. I think if there has been loss of a menstrual cycle already, and it has been greater than several months, then I would seek out medical care to make sure that there is nothing else going on. So depending upon the age of the athlete, that might be a pediatrician, or a family physician, or a gynecologist, or myself, if the athlete's a little bit older. Um, and so once that has been established that this is the cause of a lost menstrual cycle, then my first recommendation is always to meet with a sports nutritionist. So, and I think that that is also best done with having everyone on board. With the family is key to that, and I think Kara will speak a bit more about that.
Great, great. All right, well, let's move on to Kara then. I'll pull up her slide and we can go from there. All right. Kara, you ready? Try to get out of into presentation mode here as well. I am on my screen.
I only see Jessica's presentation.
Yeah, there's a bit of a lag. I have it up here. I'm just trying to pull it up.
Okay.
1 second here. It's on my screen. Here we go.
Perfect. All right. Thank you all for having me. Okay, so we'll talk about nutrition and the female athlete triad, and then I'm going to talk a lot about the REDS, which Jessica touched on a little bit.
Great. And Karen, I'm just having a little bit of trouble advancing the slide here for some reason. One moment.
Okay.
It's not moving forward.
Oh, there you go.
There we go.
Okay, so the female athlete triad, and I also think we had talked about this a little bit, Jessica and Cheryl and I, before the presentation. I think that repetition, a little bit of repetition is really good here because it sort of drives home the point from a physical therapy or a medical or a nutrition standpoint. So some of the things we will sort of go into detail or less detail that might be the same within the 3 presentations, but I think that's really important to stress the importance of this. So the female athlete triad we know is caused by underfueling for the specific training that an athlete is doing. This deficit is referred to as REDS, which is relative energy deficiency syndrome. And the relative energy deficiency syndrome not only affects the menstrual cycles and bone health, as we talk about in the triad, but it encompasses a huge array of different physiological symptoms, which we'll talk about a little bit. But the nutrition piece of the female athlete triad is this relative energy deficiency that I'll keep talking about. So in 2014, the International Olympic Committee issued a statement that basically said that the triad was basically this syndrome of relative energy deficiency, and that it affects a wide scope of issues, not just the menstrual cycle and bone health, but we're talking about immunity, protein synthesis, obviously menstrual function, physiological functions, cardiovascular health, and mental health as well. And it basically all comes down to the volume of exercise that an athlete is doing and how much they're eating in comparison to that training load. When we talk about REDS, Disordered eating does play a role, but many times, as Jessica mentioned, it is unintentional. The athlete is just not eating enough for the amount of training that they're doing. And the disordered piece might come in the fact that they feel like they're eating a lot, and that creates some issues, but it's still maybe not enough for what they need. And then we, of course, also have intentional underconsumption of calories when there is an eating disorder. So the decreased energy availability, if we can just try to remember that, can be unintentional, where we're just not matching the training load and the food together, or it can be intentional when we're talking about body composition and someone trying to decrease their caloric intake. So a lot of athletes believe that because they're eating throughout the day and they're eating at school, and they're eating before training and eating all day long, maybe in the summertime when they're training, that they're eating enough. But the problem is that it's not enough for the exercise load that they're doing. And they may feel like they're eating a lot compared to their siblings that maybe are not athletes or aren't training as high. Maybe they're eating a lot compared to even their parents or their friends who are not in the same sports. So that's where we get into a problem where it's just they're not eating enough for what they need, but they feel like they're eating because they're eating a lot. And maybe the foods that they're eating don't have enough caloric density to it. Also, and conversely, a coach may not pick up on this right away because they see the athlete eating and training, or maybe there's a travel schedule and the athlete is eating at team out of town dinners and things like that, but they don't know what they're eating for the entirety of every day in their training load. And so parents also sometimes, they see their child eating and they say, oh, the child is eating enough, but in reality, it's just not enough for the amount of training that they're doing. Many of the diet trends out there today can lead to this. So when we talk about things that are buzzwords in the media and we hear about all the time, low calorie diets and low carbohydrate diets, and even intermittent fasting. Intermittent fasting can have a place, but the place is not with high school athletes at all. And really athletes that are doing any sort of huge high training loads. And these diet trends with lack of carbohydrates and things like that really can lead to this relative energy deficiency. When a female athlete does not have enough carbohydrates on board, will affect their hormones in a way that it's not going to so quickly affect their male counterparts in high school and after high school as well. So when there is not enough carbohydrates on board, we can see a drop in estrogen. We can also see an increase in some of our stress hormones as well. And any athlete, just as Dr. Devon mentioned, any athlete who has lost their menstrual cycle due to training and this energy deficiency needs to seek medical treatment with a team right away. So this is also the slide that you saw about a little bit. So primary treatment for the female athlete triad in this relative energy deficiency is nutritional. So what we would do as dietitians and sports nutritionists is we would assess a diet recall. We would look at what the athlete's eating. We would assess their training load, how many calories they might be burning. Every athlete, and especially when we're talking about winter sports, you're going to have different needs and different training loads, especially during competition cycle, than whether you are a Nordic athlete or you're an alpine athlete or a freestyle athlete. There will be different needs there. Now, how we assess someone's diet recall would definitely depend on if there was intentional restriction or unintentional restriction. And I might just do that in a different way. Weight gain is most definitely the strongest predictor that we're going to bring those menstrual cycles back. And really what that might look like is going to be different per athlete, but it might be 5 to 10% of body weight. And looking for a gradual increase. It may be increasing calories daily, 300 to 600 calories a day. And if things are not turning around, and certainly in the beginning, restriction of exercise is also going to be a piece of that. And it may take 6 months to a year for that menstrual function Sure. Warning signs connected to deficits in nutrition. I think this is really, really important as athletes, for the athlete to recognize this, maybe even in their teammates, but certainly for coaches and for parents. So obviously it's the loss of menstrual function, which we've talked about a lot, stress fractures, gastrointestinal disturbances, pain, not being able to tolerate food, bloating, alternating between constipation and diarrhea, sleep disturbances, dehydration, cold intolerances, significant weight loss, excessive muscle cramps and weakness, which that can also be a sign that your electrolyte balance is off, and dental issues. So sometimes if we have intentional restriction and there might be an eating disorder involved in purging, then sometimes our dental professionals are the first to recognize that. We can also look for behavioral things, isolation, not wanting to eat in front of people, preoccupation with weight and performance, sometimes going above and beyond a high training load and doing excessive exercise over even what the coaches are asking. Looking at excessive use of disordered eating patterns like diet pills, laxatives, things like that, but also anxiety or depression that's increasing and difficulty concentrating in school with sometimes an accompanying slip in grades. So there is not one size that fits all. As I mentioned, a Nordic athlete or an athlete who is maybe in alpine ski racing at a high level, they will have different needs for sure. But all athletes should start fueling in the morning. They should have snacks and make sure that they're fueling around their training. They need to be eating breakfast and lunch and dinner. Performance will slip when proper nutrition is not there. I feel like that is typically the best way that I can really drive home how important nutrition is. Anything that you are not doing for nutrition, your competitors are doing. And if we want to excel and we want to be happy athletes and uninjured, nutrition is the way to go about it. So hydration is also extremely important, and making sure that our meals are balanced and they have carbohydrates and they have fat and they have protein and they have everything that we need for fueling our muscles, but also recovery. And I think teaching and going over with our athletes what the carbohydrates are, what protein is, what fat is really important. When we're talking about our major macronutrients, so we have our carbs and we have our protein and we have our fat, just making sure that when the meals are made that we have all of that there. So our carbohydrates are grains and fruit. Vegetables, yes, are carbohydrates, but mostly when we talk about carbohydrate-rich vegetables, we're talking about corn, peas, and potatoes. If we're talking about broccoli and cucumbers and things like that, you would have to eat 10 stalks of celery, which would be about this high on this table, to equal 1/2 cup serving of potatoes for carbohydrate intake. We are talking about beans, we're talking about dairy products, not cheese, but things such as milk, if it's dairy milk, and also yogurt. Simple sugars that are found in your honey stinger products and sports gels and drinks and all of that we're having, and also beans. So those are the main thing we're looking for carbohydrates. For protein, we can get protein from beans, nuts, and seeds, things like tofu, red meat, pork, poultry, eggs, and fish. And then our fats are going to also come from dairy and meat products, but nuts and seeds and oils and coconut and avocado and foods like that. So general carbohydrate needs for a young athlete. Carbohydrates are our preferred fuel for our body that they can easily assess, assess and get in there to use for energy. So we have to make sure we're taking in enough carbohydrates. Carbohydrates, again, the needs will vary greatly between athletes that are focusing on strength and athletes that are focusing on endurance. They all need carbohydrates, but the needs might be a little bit different. Just as a general view, if we're talking about an athlete that is 130 pounds, and a lot of times when we do this, we talk through kilograms. To figure out your kilograms, you just take your weight in pounds and you divide it by 2.2. So a 59 kilogram athlete that weighs about 130 pounds, might need 5 grams per kilogram per day of carbohydrates. That's 295 grams of carbohydrates a day, or 1,100 calories in carbohydrates a day. So we can get much more specific on timing and what we do pre, during, and after, but that's a pretty general rule for someone who is a winter sports club type athlete, and how much they would need. And of course, again, needs will vary with weight. So this is what 1,100 calories look like. So if we're looking at this, it could be a cup of oatmeal, half a cup of berries. Those little numbers next to there basically are me saying how many servings of carbohydrate that is. A banana, maybe some flax and nuts and yogurt, green tea with honey. So then we could have for lunch a large tortilla wrap. You're going to get carbohydrates in there, a third of a cup of hummus, veggies, turkey, and an apple. And for dinner, maybe a nice, decent sized piece of salmon, some sauteed greens, and a medium sweet potato. That would cover what that 1,100 calories looks like in carbohydrates, not overall calories. So for protein, for a non-athlete, a non-athletic person, fairly sedentary, might need 0.8 to 1 grams per kilogram a day. Athletes are going to vary widely. Are we talking about somebody doing a lot of high intensity strength, or are we talking about somebody who is doing more endurance and uphill sort of exercise? So again, for our 130-pound athlete, needs will be 1.2 to 1.8 typically for our athletes, grams per kilogram per day. If someone is doing strength training most days and running 1 to 2 hours a day, they might need 1.6 grams per kilogram a day. That's 94 grams a day. If an athlete eats animal products, it's fairly easy for them to get that if we put together a plan. If an athlete is a vegan or vegetarian, it can be done, but you really do, I have to stress, work with a professional to make sure that you can hit those goals. So this is a little overall calorie needs chart I put together. This is, again, it's going to vary between athletes, but if we look at a 120-pound athlete and a 160-pound athlete, if we're talking about a moderate training load, 1 to 1.5 hours a day, 5 to 6 days a week, I think that over a certain age, that hits most winter sports club athletes, especially in the summer and you're doing dry land. That's 2,200 to 2,500 calories a day. So that's what they would need. If we're talking about somebody with a very, very high training load, and that's for the 120-pound athlete. We're talking about a very high training load, somebody who's training 2 to 2.5 to 3 hours a day, 5 to 6 days a week. They're running, they're doing strength training, they're skiing, obviously. Then they might need 3,000 to 3,600 calories a day. And that can be put together. A lot of times when we talk about that, we're not adding so many extra meals. We're just making sure that the meals that they have a lot of density in them. So a nutrition sample day, I'll go through this quickly. I don't want to take too much time, but breakfast, again, we have our oatmeal, berries, honey and maple syrup, almonds, and then maybe for a little extra protein, scrambled or hard-boiled eggs on the side. Mid-morning snack, maybe you made some walnut banana bread. And for a little extra protein, if your protein needs are high, you could make something like that with protein powder. For lunch, we have a large tortilla wrap, third of a cup of hummus. We have our 3 ounces of turkey, avocado, additional vegetables. We have cheese, maybe we have grapes or some other fruit with that. Snacks. Some snacks that you might do: banana and nuts, hummus and crackers, a nutrition bar, apple and nut butters, dates that are filled with nut butters or things like macadamia nuts. You have your honey stinger waffles and nut butters. And if practice is in the afternoons, we have to make sure after school that the athlete is fueling properly before they go to training. This also is really, really important for younger athletes. During training, we might look at sports drinks, gels, chews, and other ergonomic aids that are needed depending on time. And then we can also talk about like a Buddha bowl, which might have 6 ounces of some sort of tofu or meat or something like that. We have 1.5 cups of quinoa to replenish our carbohydrate stores, and then spinach and tomato and quinoa and things like that. Fueling around training and competition. This is really, really important. Components of a successful fueling strategy are going to take into the differences of what you need after you're done exercising, what you need during exercise, and what you need before. Pre-training, you want to think about having enough carbohydrate to fuel yourself, but not something with a lot of fiber so that you're not going to upset your stomach. If you're training in the afternoons after school, think about that, what you're going to eat if you're having a late lunch. You probably wouldn't want something with a lot of broccoli and vegetables and things that might not digest well. You want to think about lower fiber foods. During, you want to focus on water replenishment, hydration, electrolytes. And if the exercise is over an hour, you want to start replacing carbohydrates. And that can be done with your gels, your sports drinks, things like that. Afterwards, you want to focus on recovery. So we need to make sure that we're getting enough good fats and protein in there to help restore the muscle and promote muscle synthesis. And then we also want to get carbohydrates in there to replace that glycogen in our muscles that we've used for energy. So your nutrition is definitely part of training. So I want to stress that food is part of training, eating is part of training. You cannot be a successful athlete without getting a good nutrition plan in place. And so to flourish in your sport, you have to nourish yourself. So I just want to stress that. And that's the end of my presentation.
Great, thank you, Kara. Should we just take a quick moment if anyone has any specific questions to ask right now before we move on to Cheryl? All right, I think we'll wait until we finish with all of them and move forward, okay? Oh, we might have one Q&A here. A question from Ann Patel, is chocolate milk still considered a good recovery drink? Great question.
Well, the thing with chocolate milk, well, the thing with milk in general, so when we talk about just milk by itself, the magic of milk and why that has worked for people as a recovery drink is that it naturally has carbohydrates in it, and it has natural carbohydrates in it because of the sugars in milk. They're not sweet sugars, so we don't think about it as having carbs, but it has carbohydrates and it has protein. Now, when you add chocolate milk, you're adding extra sugar in there. I really think even just plain milk actually is a good recovery drink. It's fine as long as somebody can tolerate dairy products. It's a great recovery.
Great, thanks, Kara. All right, I think we'll move on to Cheryl now. We have some more questions at the end. Pull up the new slides here.
Oh, there is one other question, but we can answer.
Oh, sorry. No, I just saw it pop up. Let's get to it. Yeah.
For younger children, how is calorie intake measured? They're so active as long as they are on the growth curve. Are they fine? So are we, what age, are we talking about younger than the children who we're talking about in this, which I think this was for over 14? 10 and a half. So if we're talking about 10 and a half year olds, and I have a son who's turning 9. So when we're talking about somebody 10, obviously we don't really haven't had that opportunity for them to start having signs like stress fractures, certainly not losing their menstrual cycle either. So you would look at growth curve for sure. You would also look at, I think typically what I see a lot is behavioral issues. So if they are cranky, if they are fidgety and they seem a little antsy and out of control, a lot of times that is a sign that they're not getting enough nutrition. Of course, you can also look at how they're doing in school, how their teachers are saying that they're doing in school, and their willingness and wanting to actually go to practice and exercise as well. But yes, you would also look at the growth curve.
Great, thank you, Kara. All right, with that, we'll move on to Cheryl's presentation. Okay, Cheryl, are you ready?
Yes. Okay. Hi, everyone. So I'm a physical therapist. I'm going to talk a little bit about some of the performance-based consequences of female athlete triad. You can go ahead, Dave. So there are some positives of sport involvement, of course, and I wanted to kind of cover these quickly because we're talking about a lot of these kind of scary negative things, and I think it's important to kind of congratulate those of you who are involved in sports, because when compared with sedentary counterparts, female athletes specifically are more likely to finish high school, less than half as likely to experience teen pregnancy, more likely to leave an abusive relationship, attend college, and then less likely to abuse alcohol. In addition to that, participation 5 to 6 times a week in sport leads to female athletes feeling more satisfied with their body image, enhanced self-esteem, and just more satisfied with their weight. So I wanted to kind of obviously not take a poll because we're all just viewing this virtually, but just kind of take a look at the first question: which of these components are composed of female athlete triad? So we've covered this through Kara and Jessica's presentation, but I just wanted to review what are the actual pieces to this female athlete triad. So go ahead, Dave, you can click on those. Yeah, there we go. Trying to get fancy with it. Disordered eating, amenorrhea, or loss of menstrual cycle, or lack of starting a menstrual cycle, and then that osteoporosis or kind of bone changes. And then what are some warning signs of an eating disorder? Just a few things that I've pulled from the research. And not all of these apply. So the ones that are highlighted are the ones that are things that maybe you see in an athlete colleague or parents are seeing in their children, or you're kind of just weighing in on some of the things that may apply to you. These are things that we want to be aware of that are warning signs. So the ones that are being highlighted are the things to kind of consider as possibly signs of an eating disorder, or you know, heading down that road. Great. Okay, so like I believe Dr. Devon and Kara mentioned, a majority of eating disorders are not intentional. So it has to do with that energy balance. And athletes may not have the appetite to really drive adequate consumption. So we've got to kind of work with that to make sure that we're getting the right calories in. High caloric expenditure and low intake is, often due to just a lack of the right nutritional guidance. So we're grateful that there are nutritionists out there that can guide our athletes here. We know, based on what Dr. Devon mentioned, that calories are really required for menstruation, also for building and healing muscle tissue after injury, and also just for growth in this phase of a female athlete's life. There's also a lack of that metabolic fuel when we have that negative energy balance. So the body can choose to basically spare calories for those essential functions in order to stay alive in the presence of a calorie deficit. And that's when the menstruation can be suppressed and lead to some of these other consequences. So this slide shows some concerns specifically involving this female athlete triad. So from my research, there is an increased risk of scoliosis, which is that spinal curvature, when menstruation has not started before age 15. Osteoporosis is 4 times more prevalent in females than males, so it's definitely something we've got to be aware of. That starvation, whether intentional or unintentional, can affect glucose levels, which lead to muscle tissue breakdown, which causes injuries. So that's something that I'm a little bit more hyper aware of in my athletes. In addition to that, there's an increased risk of injury and a 3 times higher rate of ACL rupture in females who don't have the right caloric balance. So this, I think we've looked at this picture before in Dr. Devon's presentation, but I think it's important to kind of reiterate what the difference between healthy bone and kind of that less dense bone looks like. So this slide covers some bone health statistics. So 50% of our bone mass is acquired in ages, on average 11 to 14. And women attain about 95% of their total bone mineral density by age 18. So this is a really crucial time to make sure that we're, feeding our body the right stuff and maintaining good bone health. So we've covered that estrogen is needed for skeletal maturation, meaning basically those estrogen, we know that estrogen receptors are present on bone, and they kind of inhibit the breakdown of bone. So it's important that we know that when that menstruation is suppressed, there's less estrogen circulating in your body, so we have less potential for building that bone mineral density. And occasionally we've seen that loss of bone mineral density potential is irreversible, meaning that even when menses resumes, we may not get to our height of what we want to see for bone mineral density by age 18 to 21. I have a picture here of an ATM because there's some reference to your bone bank, which I think is kind of a good visual. So basically, with your bone bank, we as we're growing through this kind of period of adolescence, we're sort of making deposits of bone over the course of time. And when we get into our 20s, kind of withdrawals start to take place, meaning bone is kind of breaking down and being used and not replaced at the same rate as it is in our adolescence. So we just want to kind of think about that we don't want to really deplete our bone bank during this period of time. We want to kind of build bone, so we want to do the things that are going to help make that happen. So stress fractures is something that's been mentioned a few times here, and it's kind of one of those cardinal signs that we may have an issue with bone mineral density, especially in this age group. So a couple statistics here. Fracture is often the first indicator of female athlete diagnosis, female athlete triad. So it's 2 to 4 times more likely in women who've lost their period or who haven't had menstruation start. There's an almost 5 times higher incidence of stress fracture if female athletes are practicing for more than 12 hours per week. So that's something to think about, especially in the presence of a low energy balance. Some of the high risk areas for stress fracture that we see in a PT clinic are femoral neck, so up by the hip, patella, anterior tibial growth plate, so down kind of in the front of your knee, the talus, which is kind of that front ankle bone, and the proximal fifth metatarsal, so kind of on the outside edge of your foot or toward the toe. In addition to what's mentioned on this slide, some of the factors which can also affect risk for stress fracture include poor flexibility, alignment issues, of course, kind of poor bone mineral density and hormone levels, increased training intensity, and then often even just technique. So I can't say enough that as a PT, we really kind of focus in and look at body movement patterns and training regimen to kind of look at where weaknesses are and specifically address some of these issues to try to really boost performance and get you back to a place where everything's working and balanced. This slide kind of covers some of the myths that I tend to see in here. So I think it's really important, which is why I highlighted that there's a significant delay in return to competition when you've got a stress fracture. Typical bone healing takes 6 to 8 weeks. And in the presence of a lack of good metabolic fuel in the female athlete triad, it could take even longer. So it's pretty much impossible to achieve optimal performance when you're in a malnourished state. And just as Kara mentioned, it's that, if you're not thinking about your nutrition, your competitors are, and they're going to be more optimally performing. Weighing less does not equal improved performance. That's definitely a common misperception. In addition to that, I think it's great to know that many Olympic records have been set and won in all phases of the menstrual cycle. So just because you're experiencing, your period does not mean that you're not going to be able to compete or that it's going to affect your performance And same with, thinking about a loss of a menstrual cycle. It really, it could affect your ability to perform and take part in some of these important competitions. And again, the consequences of this triad may not be completely reversible. So being able to kind of prevent and maybe diagnose these things early and intervene is really critical in terms of, getting this athlete back to their performance. So just, to reiterate, just fractures and injuries that come from some of these, changes in the body that come along with that low energy availability is really kind of a big setback. Being kind of pelvic floor specialized, I found a lot of different research out there to kind of cover. So I'll just kind of briefly run through some of these. But pelvic floor dysfunction is actually something that is commonly seen in the presence of the female athlete triad. So when we talk about pelvic floor, there's a sheet of muscles that sits in the base of our pelvis. And those muscles encompass the vagina, the rectum, and the urethra, which is kind of where our urine stream comes down from the bladder. So we do see with energy deficiency that it can suppress the reproductive axis, meaning, that menstrual cycle, but there can be downstream vascular effects as well. So what I mean by vascular effects is that it can that lack of blood flow can really affect some of these other systems and how the pelvic floor functions in terms of bladder and bowel health. So stress urinary incontinence or losing control of the pelvic floor, leaking urine, is actually the most prevalent pelvic floor dysfunction found in female athletes. So going along with that, there was a study done on triathletes, so doing very similar kind of high endurance, high strength related activity, that showed that pelvic floor dysfunction was actually found 37% to have urinary incontinence, 28% to have fecal incontinence or loss of stool, and 18% with pelvic girdle pain or kind of pain in the pelvic floor affecting function. So that's an interesting statistic for triathletes. In addition to that, we kind of cover some other statistics here. Female athletes with disordered eating are 3 times more likely to experience urinary leaking than athletes without. 1 in 4 female triathletes with pelvic dysfunction also screened positive for at least one component of the female athlete triad. So these things kind of are seen together often. We know that low estrogen state can kind of increase risk of some of these pelvic floor disorders. The impact of strenuous exercise can prematurely weaken or fatigue those pelvic floor muscles. Some of those supporting connections of the pelvic floor can be weakened with increases in mechanical load and increased pressure from the abdominals with heavy breathing, which can really affect the ability of the pelvic floor to close around the urethra, which is why we see the leaking that comes along with it. There's also been some studies that show that pelvic floor muscle efficiency can be compromised in the presence of a vitamin D deficiency. So I don't know if Kara can maybe speak to that a little bit if we have questions, but it's important that we have a nice balance of our vitamin levels to keep everything functioning systemically. And finally, there's question marks about this, but there are some studies out there that show that infertility may result due to this prolonged lack of an ovulatory phase of the menstrual cycle. So another kind of down the road long-term risk that's worth kind of thinking about and being aware of. So I kind of put this slide together based on some of the specific winter sports club female athletes. So some of the research that I found shows that travel for competitions can actually lead to some irregular eating patterns, which can suppress your resting metabolic rate. Another thing that I found was that suppression of this resting metabolic rate can decrease your lean mass, can increase body fat percentage when experienced over prolonged periods of time. So all of this is going to throw off your ability to perform. Extreme weather conditions can also lead to a decrease in body mass due to dehydration if we're not getting in the right amount of fluids, and just fluctuations in heart rate. And the incidence of amenorrhea in endurance athletes, this is specific to runners, but I feel like runners have a similar training regimen and a similar energy expenditure to some of our distance Nordic skiers, and that can be all the way up to 65%. So I put this slide together. This kind of covers some of my physical therapy type treatment recommendations here. So it's important that we evaluate what the athlete is doing in terms of a training program and what those demands are, also what their goals are as an athlete and what kind of competitions are important to them. So we like to kind of have a physical therapist or exercise physiologist when it comes to this point, kind of look at that training program and look at what we want to do. So we should look at revising a training plan, especially in the presence of a stress fracture or some sort of injury. And periodization with active rest cycles and varying intensity is important. Of course, every athlete that comes through the door to a PT clinic is going to be, individually evaluated and assessed for specific needs and specific areas of weakness. But we like to really create a very individualized program with follow-ups to kind of check on progress and kind of progress through the program. Adjustment of training, of course, requires collaboration between PT coaches, athlete, and absolutely parents. Specific to a stress fracture, some of the big concerns that I have as a PT are those repetitive kind of high impact type activities that we'd want to kind of keep you away from so as not to further damage the bone. We want to allow for healing. Repetitive heavy loading of that affected limb. And then limitations in flexibility or postural adaptations that come along with pain or changes in muscle tone. This kind of requires graded exposure to sport-specific exercise and a slow progression through a training program. So I just wanted to put on here, the American College of Sports Medicine put out a position statement on the female athlete triad, and this covered basically that it's really important to have a multidisciplinary team approach when we have an athlete that fits this diagnosis, and that includes a physician, a nutritionist for sure, and then a mental health practitioner if there is an actual diagnosed eating disorder. We want to really focus on increasing energy availability by increasing that caloric intake and decreasing the energy expenditure as needed. So over on this other side of the slide, I just have a little kind of basic calculation for determining using body mass index and percentage of your fat-free mass. This is absolutely something I would defer to Kara. I think she's got much more in-depth ways of assessing an athlete. So what can we do about it? From a physical therapy point of view, really any female with signs or symptoms should be further evaluated and cleared for participation. So I think it's really important as parents and as coaches to really screen everyone and maybe multiple times throughout the season. Some signs and symptoms which we've covered throughout this presentation is kind of that menstrual irregularity, maybe a history of stress fractures or prolonged recovery from injury, or of course an identified eating disorder. Exercise can contribute to energy drain, so with the right amount of nutrition, we can really address this appropriately. I put on here a little screening tool, which I think is very similar to the one that Dr. Devon posted. So just some things to kind of read through and just be aware of, maybe as coaches or parents or athletes specifically. Just kind of take a look at some of those questions. If there's a number of these that we're checking yes on, then it's probably something worth seeing the pediatrician or finding a physician to dig a little deeper. So the take home doesn't look like there's anything there. Oh, I must have done something fancy with it. So there's a few different things here that I wanted to just kind of review based on my presentation. But basically this disrupted caloric balance is associated with significant changes in our physiology and body composition, which absolutely affects performance. Like I said prior, the lack of knowledge of nutritional balancing can be a really big piece of this. It may not be an intentional low energy situation. Prevention and early detection is very critical, and this takes really collaboration between coaches and parents, and even just athletes if you see it in a friend that's practicing with you. The loss of that peak bone mass can potentially be irreversible, can lead to fractures or osteoporosis prematurely. Low energy availability also affects your muscle tissue healing, and this is something I see a lot in the clinic. So that contributes to all kinds of soft tissue injuries, including ACL ruptures, recurrent sprains, or muscle tears and strains. Those low energy or low estrogen levels do contribute to pelvic floor disorders, and there's a variety of things that we see in that regard. Treatment involves adjusting that energy availability, so meeting with a nutritionist and really digging deeper into that, and then maybe adjusting energy expenditure as well to find that nice healthy balance. And finally, just reiterating, there's really a multidisciplinary approach, and we want to work as a team with the athlete and get everybody on board, everybody kind of coordinating care so that this is a swift return back to sport and menstrual cycle. So that covers my presentation.
Awesome. Thank you, Cheryl. I love the transition from the three approaches. It's really good to see this from three different angles. So thank you very much.
Sure.
I'd love to have a great conversation now. So do people want to take a little quick break, or should we dive right into some questions here? How about from the panelists? Does anyone need a break, or are we good to go right ahead?
I'm good to go ahead.
Okay, great, thank you. And to participants out there, if you raise your hand, I'll go ahead and unmute you so you can ask questions here. And while we wait for some to roll in, I did have one question. You a couple of times mentioned this screening tool or some metrics. Is that something that you recommend that organizations should be doing it all at this age? Should parents just be doing that, or should the Winter Sports Club potentially be doing that at this age right now?
I can speak to that. The research that I was reading basically shows that at basically a pre-season type, physical exam, those are some of the questions that should be asked, and direct questioning is better than kind of beating around the bush. I don't know if you agree with that, Dr. Devin.
Yeah, that was the context in which I saw that questionnaire being used in, was for sports physicals as well. But honestly, I think that anyone can use those questions, whether it's family members or friends.
Thank you. Great. John, do you have a question? Merritt does.
I see a question in the chat from Susan.
Go ahead, get that, Cheryl. Yeah.
So it says, can you provide a bit more perspective on flexibility and stress fractures and where that relationship kind of sits? So oftentimes, to me, there is a really big difference between being joint flexible and being muscle flexible. So I think this speaks to muscle flexibility. If we've got really tight muscles, where those muscles tendinous junction meet with the joints or meet with the bone, if those muscles aren't nice and supple and we've got good flexibility, we're going to potentially have a issue with kind of pulling at that tendinous junction on the bone, and that's what can lead to stress fractures or even ligamentous tears. Lots of different injuries come along with a lack of flexibility. So I personally feel like if everyone's stretched, I might not have a job.
Great. And Merritt, you had a question. I think you're able to speak now if you want to jump in there.
Oh, look at, we joined the panel, so I don't know how we did that, but it's Millie. Jessica, this maybe is a question for you.
Hey, Millie.
That you mentioned not using hormonal Nice to see you. Thanks, you guys. Really awesome. And I'm learning a ton. So, so not using the hormonal contraceptives to manage the secondary amenorrhea as
Yes.
much as maybe we had previously. So my question then with that is, a lot of young women are using either hormonal contraceptives, either long-acting birth control or oral contraceptives for other reasons, whether it be dysmenorrhea or acne, or, and is that a problem? I mean, is that something in certain athletes that we want to consider avoiding, or we should be taking extra caution with? I guess I wasn't up to speed on the.
Yeah,
nutrient
now
and-
obviously you can't use the menstrual cycle as your indicator, right, of energy availability, since they're taking exogenous estrogens to regulate their cycle. So you do lose that ability. Whether that is something where you should or should not do that, I mean, it's really hard because it's so personalized to that person and why they are taking it. So certainly I don't have any problem with taking oral contraceptives for contraception or any other reasons in that age group. But one thing that I have seen, and I've seen this, in friends and family members and patients who come to me as well, is, oh, I've lost my menstrual cycle, so someone put me on birth control. And that's what we don't want. So
I think that was a kind of an approach for a long time.
yes, it was. And I think we have, it was a very common approach. And so we've developed more and more data on it. And the data has, I think, become increasingly negative. And the other part that I don't care for about it is that I think it provides a false sense of security. So, okay, well now here we are and I'm having my menstrual cycle, so everything must be okay. So
great, perfect. Thank you so much.
Great. And there's a question in the chat that I can ask from Denise Faherty. Great presentation, ladies. What is the percentage of female athletes 14 and over that fall in the female athlete triad? Any data out there? Only saw info presented on female runners.
So that there is quite a bit of data out there. It depends on just which study that you read. So, and also a lot of it is sports specific too. So, I could quote a bunch of different numbers off my head, but I don't know how relevant any of them are going to be. So the other common sports, other than female runners, you can see it a lot in figure skating. Gymnastics are also big sports for this. And then the other thing that I want to mention, and just about your comment on, you only saw the info presented on female runners. So the reason the name was changed on it from female athlete triad to relative energy deficiency and sports syndrome, was this realization that this syndrome can also occur in men too. And so it's harder to diagnose because you don't have that red flag of losing a menstrual cycle. But I have definitely seen this in college aged track and field athletes who are just running a ton of miles every week and present with very low testosterone levels in a 20-year-old male. So that was the rationale for changing the name of it.
Are there any other questions out there? We don't have any right now. I have a lot. I have one. Are there any other markers? And one I was thinking about was low iron levels, low ferritin levels, perhaps. Is that something that that athletes and parents might be able to pick up on just in a routine blood panel? Anybody? Who should take that?
I was going to defer to Kara on that one. Sorry,
I would, that is an interesting question, because I do think that if an athlete is doing something, especially running, that comes to mind. And as we know, a lot of the winter athletes, this presentation is to the Winter Sports Club. They are also on cross country, a lot of girls, and they do a lot of running in their dryland training. So even if their main sport is skiing, they're runners also typically. I think if fatigue is setting in and things like that, I don't know with necessarily maybe with, certainly if you have a deficiency of nutrients and calories coming in, you can easily become anemic. But I do find that ferritin, serum ferritin looking, which by the way, for everyone out there, that's your stored iron stores. I feel like that's not always checked. And I think it's something that is good to ask and request that it's checked. Dr. Devin might check that, but I don't think it's common that everybody checks that. And I think it's actually good to check that to see, because you can actually have your hemoglobin and hematocrit, which is typically what's checked, that could be at a okay level, but your stored ferritin is really low. And that certainly will contribute to fatigue and all of that. And that can come about by not fueling yourself enough, if that answers.
That's great. And I think Lynn Hodges and I were thinking about the same thing at the same time, because she asked the question in the chat, thoughts on girls, women, and iron levels in endurance athletes, with a question regarding ferritin tests, what acceptable numbers, how specifically to increase iron levels, supplements, liquid, solid. I think you answered part of this question, but kind of that next step a little bit in terms of addressing it.
Well, we do want to always look at food first. So we want to look at increasing iron stores from the food, because it's bioavailable. And of course, if you're also taking that in and you're trying to increase that with food, you're getting a lot of other nutrients as well. So that's always why we do want to look at food first. But certainly girls of menstruating age will often need to supplement with iron. I always look for something that is, I like supplements that are whole food supplements. The body tends to be able to absorb them a little bit better, and they often don't have as many gastrointestinal side effects. So sometimes you have to play around a little bit with what works with each individual, because we all will be able to, men don't typically take iron usually, but so for women, we will have to look at the different types of iron supplements that we're taking. I always say you want to kind of start lower. You don't want to just go with a super high amount. You want to start lower and then increase it as needed, if that's needed over food. And we want to look at the different types for each person, because everyone will not be able to tolerate gastrointestinally all the different types of iron.
Great.
That answers.
Yeah. Anything else from Cheryl or Jessica on that question? Great. Well, I want to be respectful of your time. Thank you all so much. Are there any other questions before we sign up and wrap up here? I did have one more, just because I think it's a really powerful topic that you brought up, is the idea of a team approach as a solution here. Is that something you could talk about a little bit more?
I think Kara touched on it on one of her slides a little bit, with all the different scenarios that she put forth. And so I think it really does take a team to recognize this. It comes with some of the colleagues on the sports teams, with coaches, with parents, really pointing out. I feel like a lot of adolescents won't themselves come forward, especially if they're missing a menstrual cycle. And so that's the importance of the team approach that I see. And then of course, addressing it as well with the nutrition.
And if I could add, I think that on the preventative side, making sure the coaches and the parents and the athletes are really on board, so we keep that prevention side going, is important. If the female athlete triad and relative energy deficiency and syndrome is diagnosed, that there is that team of a physical therapist, the doctor, and a dietitian. I think that's really, really important, with the added piece, 100%, that if the relative energy deficiency is from intentional restriction, that there is a therapy piece in there as well. So the team approach is of the utmost importance, I think.
Great. And Cheryl, you had that in there as well. Do you have anything else to add to that, the team side of things?
Yeah, I mean, I think the team, for sure, based on that ACSM position statement, is physician, nutritionist, and maybe mental health therapist. But I also think when we're talking about our winter sports athletes, there are big performance goals, and we want to really honor that. And so I think PT or an exercise physiologist, personal trainer, someone that's specialized in assessing the human body and being able to really, once we get that menstrual cycle back, if that's a scenario, and once we get our nutrition levels back, really train you so that you're not seeing those down the road injuries that are going to affect performance, is also going to be pretty important. So I think there's a lot of disciplines that can have a role, and we'd love to work together on helping people.
Thank you. And we did get one more question from Victoria Zlaboni in the chat. You mentioned denser foods versus adding several more meals. Do you mean just high calorie foods? Does that develop bad habits? My younger daughter does not like eating, and I don't think that will change.
So that could be twofold. So for an older athlete, we can look at, to be honest, a lot of times I have worked with high school and young, let's say high school and young adult, maybe postgraduate kids that are pretty young still, but maybe they're doing endurance mountain biking, racing, things like that. Their needs are so high. Sometimes it's often really difficult to get as many calories in as they need. And so a lot of times what we are doing is at meals, so they're not eating 6, 7, 8 times a day, we are adding a lot of calories into those meals. So that might be as simple as swirling peanut butter or almond butter into your oatmeal. So it's not just the oatmeal, it's that. That's not adding a lot of bulk, it's adding a lot of calories and nutrition. And I think for younger kids, so when we're talking about your daughter, and you said she actually doesn't like to eat much, you can slip a lot of those things in to increase the caloric density without them really knowing. I can tell you I do that with my son all the time because he's a little 50-pound, 4th grader. So I do that a lot. So he doesn't think I'm just trying to, he's not intentionally not eating, but he might get full and I just slip calories in there. So I think a lot of times with the younger kids, you can just slip calories in when you're just trying to increase their nutrition. And for the older kids, slipping those calories in, like I said, in simple things like swirling nut butters into the oatmeal can help them reach the goals without just adding a whole nother meal or something like that. And they feel like they're eating the whole day.
Great, thank you, Kara. All right, well, out of respect for your time, it is getting late. Thank you all so much. This is a very excellent presentation, and it'll be a great resource for us going forward. I have recorded this, and if it's all right with all of you to provide this as a resource for our club and for parents and athletes going forward, this is a very comprehensive look at this. So thank you so much. And as Cheryl mentioned, sports are so positive. This is one of these things where I think it can be sidetracked a bit, right? So we really want to address this and provide more education and awareness around this. So thank you all so much. Have a good evening. And if there are any more questions, maybe direct those at me and I can pass them on to the panelists if they're might have some time to answer those separately. So thank you all.
Thank you for having us.
Thank you.
Thank you.
Bye.
Thank you.